Good afternoon, everyone. My name is Dr. Philip Chan. Welcome, everyone, to this CME event sponsored by Brown University as well as Lifespan. I'm extremely pleased to welcome Jeff Bratberg, Dr. Bratberg, for presenting today. Dr. Bratberg is going to talk to us about implementing physician-pharmacist collaborations for public health. Dr. Bratberg is a clinical professor at the University of Rhode Island College of Pharmacy. He's been a member for over a decade on faculty there, and I've known Dr. Bratberg for a very long time. He's one of the first people that I ever met when I came to Rhode Island when I was a medical student, actually, so very long ago. But he's been involved in pretty much every single statewide effort related to pharmacy-driven initiatives and public health that I can think of, ranging from H1N1 to, of course, the COVID pandemic, to things like Ebola, et cetera, et cetera. So Dr. Bratberg, thank you so much for joining us, and please take it away.
Thanks so much, Dr. Chan. I guess you make me feel old, but I always feel young talking about public health because of all the excellent things we get to do in Rhode Island between pharmacists and our prescribing clinician or physician colleagues. So I'm going to try to get through this probably a little quickly, but I really want to answer questions. So if you have questions, put them in the chat and we can discuss those at the end. So first, we're going to go through no financial disclosures here, and the learning objectives I'm going to repeat. So first, we have to talk about how do we collaborate in a legal way. So we're going to talk about prescriptive authority, collaborative practice agreements, and standing orders. And one of my passions and innovations in Rhode Island is using opioid use disorder medications. So one thing that we've probably heard about is the triple aim or the quintuple or the quadruple aim, and now it's the quintuple aim. So 5 years or so ago, we looked at what are we trying to get out of health here. So we want to, of course, enhance the patient experience, motivate patients, meet them where they're at, improve outcomes. Those outcomes also extend to population health, some starting at the bottom and going up, prevent disease. So we've been a big presence in that, just in healthcare and pharmacy in general. Of course, we can only do that if we're also reducing overall costs and analyzing that. This can only be done, and this is implicit in the pandemic in terms of we can do all those things, but what does our healthcare workforce look like? What is their well-being, preventing burnout? And really all of these goals incorporate health equity, and for whom is quality of health improving? So one of the things I study in OUD is the inequities or disparities in health. So African-American or Black people face remarkable access barriers. We're talking about access to public health. In this particular disease state and many others, but in this one, if a person who's African-American visits a physician, they're less likely to get a prescription for medication to treat opioid use disorder than their counterparts. If they go to the emergency department that administers buprenorphine, they're less likely to get a prescription there if they're diagnosed with opioid use disorder. When we look at pregnancy, even in this, we have one of the highest Western world mortality rates among Black and African-American pregnant people. If they have OUD, opioid use disorder, they're 37% less likely to do it. So we have to think about ways in that health equity space to do this. Even in maintenance, looking at database studies, patients who are of Medicaid with OUD, we compare the racial qualities here. Those who are African-American are almost half as less likely to be prescribed MOUD than white folks. And we look at COVID-19, we saw massive increases in overdose and also access to OUD, but the access either was maintained or increased for people who identify as white, but actually decreased and maybe maintained in some studies for people who identify as Black. So we really have to think about that. So I thought that was a great introduction to say, when we look at buprenorphine access, or really sort of medications of public health importance, buprenorphine and methadone are opioid agonist therapies on the World Health Organization's essential medication list. Many others are on that. But stigma and discrimination, going from right to left, really start at the policy level. People make policy, policies end up exacerbating these racial differences. And because patients and prescribers and pharmacists are part of society and influenced by the policy directly or indirectly, there's stigma and discrimination at every stage of the way. So we have to think about that for some of these public health drugs. So where do pharmacists fit in? So I really like this. I cut and paste this from the National Association of State Pharmacists, National Alliance of State Pharmacy Associations, or NASPA, and they're improving the health of communities. You can scan that QR code and find these things. So pharmacists, again, for those who don't know, we get 6 years of training or more. They take a licensure exam. These are licensed health professionals. We also take a law exam that we'd like to get rid of because other health professionals don't have to take a law exam. We get additional education. I have 2 postgraduate residencies. I am doing a public health project with a pharmacy resident at URI right now and Walgreens. Again, we've had this Pharm.D doctorate for 20 years now. And so what do we do? In Rhode Island, as of 2022, we had over 1,100 pharmacists. We know from some research from a colleague of mine, Lucas Behrenbrock at Pittsburgh, nearly 90% of Americans live within 5 miles of a community pharmacy, even in rural areas, 35 times more likely to visit a pharmacy versus 4 times at a PCP. And we know that when we look at the number of providers' offices in those communities where there's higher poverty rates or where 30% of households live in poverty, we see more pharmacies there. So this is a way to incorporating pharmacists in the care, collaborative care, or independent prescribing. We know pharmacies can reduce that. Since May 2020, there's been a 200% increase in the number of pharmacies with point-of-care testing waivers, and we'll talk about test to treat there. There's a federal law, as Congress tries to just keep the government open today and tomorrow, we hope. Test to treat is not part of that bill, unfortunately, but we're going to keep trying to pass it. So we'll talk about COVID, but COVID, strep, flu, RSV, these are things that we see in primary care and family care and obstetrical care, STIs, even H. pylori. Test to treat can be done in the pharmacy. What do you have? Give you an instant result, give you the therapy right there. So when we look at this, COVID-19, we saw 42 million tests. Probably some of us, maybe all of us, got tested at a pharmacy for COVID-19. Half of Americans got at least one COVID shot at a pharmacy. 300 million vaccinations, resulting in hundreds of thousands of prevented hospitalizations and deaths. And again, that's just one acute pandemic emergency disease. When we look at chronic diseases, almost half of all adults have one or more chronic diseases. At the top there, they account for 85% of all U.S. healthcare costs. And this is really stunning to me. $4, sometimes it's all about the money and not hospitalizations and deaths, but that's implicit in that cost equation there. $4 are saved for every dollar spent on pharmacist service. To me, it's a no-brainer. We talked to the legislators about that. Even influenza, we saw deaths this year. We saw it's presumably over now, but twice the hours offered for giving immunizations are in pharmacies versus providers' offices. I've taken my kids to get vaccinated, on weekends. When we look at pharmacies in 2020, that flu season, 18 million shots versus 10 million at providers' offices. It's not a competition here. A rising tide lifts all boats. And now 6 states and probably a few more where you can prescribe antivirals at the pharmacy. So the thing is, we're not trying to take away business. We're trying to close gaps in care along some of those racial and economic lines. Of course, opioid crisis data came out, I think yesterday or 2 days ago. It's actually probably higher. We saw nearly 108,000 total drug overdose deaths, the majority of them 80,000 or more from opioids in 2022. So massive amount of preventable death. There are opioid medications that people can give. One of them is naltrexone, 46 states, and now it's 47. Rhode Island allows that. And then again, direct authority to prescribe naloxone has been associated in one study with greater care. We'll talk about standing orders. Naloxone standing order states also show an association with decreased deaths compared to non-standing order sites. I know a big focus we're going to talk about is HIV and substance use. Of course, there's a large Venn diagram and the patients affected by those things. So if pharmacies are going to figure out ways to provide opioid use disorder care, they should also be preventing or treating HIV. They are a key part of the CDC's end HIV epidemic. And so 8 states for PrEP, 9 states for PEP. This was before we passed our bill last year. So it's at least 9 and 10. We can do both of those things, and I'll go into that. So that's just sort of talking about public health writ large. What can pharmacists do? What are you familiar with pharmacists doing? Immunizations, maybe testing, maybe test to treat, providing antivirals. Where do you send your patients to get that? In a community pharmacy setting, some of you probably work with pharmacists in your offices where they can use CPAs to modify, initiate care. But what's lacking in Rhode Island that exists in some other states are really the center of this three-ring diagram here. Is we can expand scope of practice to provide more public health and connect people to primary care, but we have to get paid for that service. Nobody does things without money, and that payment really needs to be equitable. And so there's a practice standard we heard at a meeting in Newport, Rhode Island last week, where Idaho basically says pharmacists can do anything any other provider can per their training. So it's more of a not listing what pharmacists can do, but it's saying what do other people do, pharmacists can do it, and they can get paid for that service, and they are. So pharmacists, for example, in Idaho are prescribing buprenorphine. They can get DEA licenses. That's a huge expansion of care in a state that has frontier and rural regions more plentiful than here. So the goal here in scope of practice is really to increase access to care. We need to address these public health priorities, whether it's COVID or flu or strep or RSV. We need to reduce that spending, and it may seem counterintuitive to pay us equitably, pay pharmacists, I should say, I'm one of them, equitably for this care, but it really saves so much on those very expensive, unnecessary, preventable hospitalizations and ED visits, and ultimately reduce health equities, the pinnacle of our quintuple aim. So how do we get pharmacists to do these things? So there's really two different ways, and I like these slides, which I got from a talk my colleagues gave in another pharmacy meeting in December. So dependent prescribing we have in Rhode Island, where the ability is delegated by a collaborating prescriber. I think that's great. It can happen in clinics. It can happen in community pharmacies. It can happen with data systems that exchange care. So for example, several large chains have EHRs that we recognize that integrate with clinic systems or hospital systems. So some of the dependent arrangements that you are familiar with are probably physician immunization protocols. That's a protocol. Physician signs off, says you go to your pharmacy, pharmacist chooses your vaccines. Our state scope of practice says they can give any ACIP approved vaccine. That's phenomenal. Collaborative practice agreements, I'll talk more about, and standing orders are things like naloxone, but it's a dependent, I assign you to do this, you need these kinds of training. Independent is that sort of Idaho idea, or I'm now a licensed pharmacist in Ohio, where I'm doing a grant to expand pharmacy-based addiction care. I'm going there in a couple weeks to talk about what I'm doing. This is where the pharmacist has prescribing ability for a drug or a device. There's no delegation. They're signed by the pharmacist. And this was recently passed last year for hormonal contraception. So what are some examples of our current standing orders? There's standing order regulations in our state. So this is naloxone at individual pharmacies. And there was a statewide standing order, sort of an emergency standing order to allow antivirals to be prescribed by pharmacists. Many were uncomfortable doing it because of lack of knowledge of the full patient's profile due to interactions and things. But in some states, it was successful, or when that information was available. I've actually written and talked to Dr. Chan and others at the health department about the middle one there, statewide emergency contraception. Currently, there's over-the-counter contraception. There's also prescription emergency contraception. Massachusetts passed a statewide standing order saying you can go to a pharmacy, they can do a quick evaluation and determine and have insurance cover under that standing order EC in the appropriate time period for the appropriate patient. Our HIV PEP and PrEP bill actually allows independent prescribing authority, standing order, or CPA. And so we're pending those regulations. And because there's now naloxone over the counter, which is $45 at most pharmacies in Rhode Island, if you find it on the shelf, most states don't have it on the shelf. Another research project of mine is to incorporate those over-the-counter products in our state, in our naloxone standing order, make it statewide. So if someone grabs it off the shelf and they don't have $45, they can run it through their insurance, or as currently their HSA or FSA. So I use this term CPA, but just think of this as standing orders are delegated authority that kind of cover a large area. CPAs were originally designed to say, Dr. Chan and Jeff work in a clinic, and Jeff's been delegated information to do things. So they're called collaborative care agreements. A consult agreement is the Ohio form. There's standing orders, physician delegation. It's all about a formal relationship, delegating those patient care functions and the conditions that are negotiated. So for example, in our state, CPAs need to be approved every 2 years. I was at the Board of Pharmacy meeting yesterday, and they had some CPAs, some new ones, and some to be reapproved. If the board approves it from pharmacy, the Board of Medicine approves it, then it's good to go, and then it's reviewed every year. So there's updates to disease states and things. I think that's an appropriate way to work. But the key thing is pharmacists do not currently get paid in these CPAs. So if I was in a relationship with Dr. Phil to Dr. Chan, he would be able to bill for my services. It's very confusing. Some states have figured it out. Maryland, Virginia, Ohio have figured out how to make sure that the person doing the service actually can bill for their service and get paid. And the collaborating prescriber or physician gets the advantage of more care being delivered to their patients and communities. So we famously did a CPA for buprenorphine, and we could start, continue, or discontinue therapy with data waivered prescribers at the time, with opioid treatment programs. We worked with general pharmacies to delegate those pharmacists to do these things. So basically on-demand buprenorphine. Really, it's a longer study. I encourage you to read it. It was in the New England Journal last year. Our 30-day outcomes were phenomenal. But we really reached with this sort of walk-in addiction therapy an enormous, we were able to alleviate enormous social and economic disparities. 76% of the folks in our first 100 people didn't have access to a vehicle. This is Rhode Island. Imagine if you were in a more rural state, 44% were unhoused. And when we look at the disparities compared to, or we look at and compare the Rhode Island census, that's the state census on the left, you know, almost 20% people identify as BIPOC, and it's broken down there, 34% in our study. So this is at least preliminary, small study data to show on this important condition that we can remove those disparities. So just as a reminder, let's think about what provider status is and why it's important and why we're pushing so hard. And we have a bill in the state to try to get provider status, to get equitable payment for services within that scope of practice. So payer recognition, that's that credentialing process that physicians and nurse practitioners and PAs probably know. Scope of practice is determined by the legislation, which we've expanded to include 3 years ago, med administration. So your pharmacist can administer those medications that you write prescriptions for your patients or put in a protocol. That's an important service that any immunizing pharmacist can do. We'll talk about HIV, PEP, and PrEP and hormonal contraception. But again, those mechanisms need to be equitable as well for full provider status. So one place that has an integrated health system that shares data with all its providers is the VA system. So my colleague, Haley, Dr. Pals in Wisconsin, in a rural VA, manages addiction there as a clinical pharmacy practitioner. She's the primary prescriber, and she basically, in more slides than this, talked about how pre-DEA, she had sort of delegated authority from DEA licensed psychiatrists. Then the X waiver got some prescribing authority, would be delegated there. And when the X waiver went away, it was open season. She had a DEA, and she now independently manages her patients with all the supports there, right? And this is in an ambulatory setting. Referrals for whole health, pain, ID, and can also bill for those codes within that system. So hundreds, probably thousands of buprenorphine prescriptions written independently in the VA system by pharmacists who have DEA licenses. And so that goes to this slide about what I think about all the time and what I think about for the nation, since all states have their own separate medication, or I should say medical and pharmacy laws, is we need state DEA recognition. Pharmacists can't write controlled substance prescriptions unless they are able to get DEAs. The feds say, state, you determine that. There are 12 or 13 states that allow that to do it. For example, in Massachusetts, pharmacists in inpatient settings can write prescriptions for controlled substances. The other thing I'll point out a little bit here, but just to foreshadow, is perform and interpret and bill for lab tests. So we have scope of practice to do lab tests. We don't have a payment mechanism to actually analyze those lab tests. And I think that that's an equitable thing to do. Then there's things like the number of pharmacists, physicians, who signs it, things like that. I'm interested in CPAs that include community health workers, peer recovery support specialists, social workers. Make sure that this team-based effort, that everyone's getting reimbursed for their efforts. So prescriptive authority, state DEA registration includes mandated DEA substance use disorder training called MATE training. And then again, equitable compensation and insurer recognition. So poll question, which of the following best describes an independent model of patient access to meds of public health importance from pharmacists? So an immunization protocol, DEA registered pharmacist prescribing buprenorphine, a health official issues a standing order for EC, or a pharmacist in a clinic is delegated to change and start insulin regimens. So I think put your answer in the chat, and maybe Dr. Chan will tell me what's going on. So you can just type A, B, C, or D. Or yell it out. I won't say your name.
We have an answer of C.
C is incorrect. So that's delegation. I'm just going to answer these questions. So A is an immunization protocol. So that is a delegated authority. C is incorrect because it's the state health official delegating pharmacists to do EC, like in Mass and hopefully in Rhode Island. D is incorrect because it's delegated authority. You want to look for the pharmacist actually prescribing. That's an independent model of patient access. Okay, moving on to HIV. Please, if you have questions, put them in the chat. Think of them. I'm going to have time at the end to talk about all this stuff. So probably a lot of you have encountered people with HIV and understand the stigma and discrimination, health inequities there. And so I'm proud of the US for and the CDC for establishing these qualities to end the HIV epidemic, right? Diagnose all people, treat them, prevent. This is the classic HIV cascade of care. So we're going to talk about really prevention. So just because I'm going to talk about the current law that's passed, I wanted to make sure everyone knows the difference between post-exposure and pre-exposure prophylaxis. And Dr. Chan can correct me if I got any of this wrong. So post-exposure prophylaxis, you've been exposed, you need medications within 72 hours. So that's important for best efficacy. You must be HIV negative, but you can give a first dose before you do that. You take it for 28 days and you're done. There's only oral therapy approved for this. It is very, very effective and well tolerated. So patient safety is important. Pre-exposure prophylaxis is people with ongoing risk. You're taking regimens taken daily. You have an oral regimen and an intramuscular regimen. So when I mentioned that we have pharmacists have medication administration privileges, I made it sure when helping draft the guidelines and the regulations that pharmacists can give those drugs for PrEP that are intramuscular. And so that's important. These are also well tolerated, very effective. And again, there's repeated testing involved in that process. So I looked at sort of the Healthy People 2030 guidelines. And just to look at this, that we do need all hands on deck here to reduce the number of new HIV infections to prevent them. And so as of 2017, we 2019, we had 34, nearly 35,000, 90% reduction. So they want to decrease. We need pharmacists to do this. Importantly, when we think about who's using PrEP and who's using by these racial and ethnic qualities, we look at the green lines are the percent of PrEP users. The blue lines are percent of new HIV diagnoses. So we look to the bottom, white people are the highest percentage of PrEP users and the lowest amount of new HIV diagnoses, which makes sense. We see Black people and Hispanic or Latinx people with the lower percentages of PrEP use and higher percentages of HIV diagnoses. So there's an unmet need here, and this is from AIDSview, a great website. When we look at this, I think this is a more dramatic slide. In 2022, there were 5 Black PrEP users and 9 Hispanic PrEP users for each diagnosis, compared with 36 white PrEP users for each HIV diagnosis. So since pharmacies are located in those areas, yes, there are pharmacy deserts, there are contraception deserts, there are primary care deserts. These are, I'm not going to dispute that, but we do need everybody involved to try to solve these intractable public health problems. When we look at male-female, there's 16 PrEP users for every new HIV diagnosis among men. We have 6 female PrEP users for every new diagnosis there, so majority are male. And when we look at teenagers and young adults, this is key here, 13 to 24. Pharmacies can serve, I think, as a gateway to primary care for people who are not getting it, who are underage. And when we look at the laws we passed, I think that there's an underutilized effort from pharmacists to advocate for this group of folks. They're least likely to have primary care physicians, they're covered under parents' insurance, things like that. So you can see 13 to 24 has the greatest unmet need. So what does a patient-centered HIV pharmacy services model look like, perhaps in Rhode Island? And this is really like a pharmacy service model for any chronic disease, not just public health. So it's individualized patient assessments, med reviews, customized patient-centered interventions. Really in the middle there, harm reduction. Pharmacies in Rhode Island sell thousands of syringes a day. In fact, we know from our statewide Encore program that they pick up 110% of the syringes they dispense. So people are getting syringes from somewhere else. My thought is that that's pharmacy. We're not proven on that. We look at provider collaboration. Those are those CPAs, standing orders, and sustained relationships. So even in an independent pharmacy practice prescribing model, I completely advocate for referrals to and monitoring in with our colleagues, whether it's a community pharmacy and an office or actually within that office setting. Here's just some from the New York State Department of Health, the AIDS Institute. Here are some folks who may benefit from pharmacy access to PrEP, right? Reporting a recent STI, unstable housing. We saw that with the substance use disorder folks. They have a partner living with HIV. They report intimate partner violence. During the pandemic, I was impressed with France actually was a main referral source because pharmacies were open, one of the few essential services there, and primarily women, but people could go to the pharmacy and report intimate partner violence and get help through pharmacists. We look at mental health disorders, again, substance use and pregnancy or planning a pregnancy. I'm going to kind of gloss this over, but I really want you to focus on the triangle in the middle there. This is from some colleagues in San Francisco. It's an older study, but looking at what do we need to implement this? Because I know that people say, well, you've given the authority, maybe you're making sure pharmacists get paid for it, but are people going to do it? And so if we have leadership, which we have, doing this talk, I'm happy to teach this, and I do teach this at our College of Pharmacy. I know it's taught at the medical school and nursing schools. So we have leadership with collaborators there. We look at organization on the right there, adapting the pharmacy patient care space, building a place for counseling, creating those communication portals, defining workflows. Other folks have done this. We're just adapting. We look at HIV risk assessment, education. In some places, there's phlebotomy, even where pharmacists can do that. And so I just want to say, you're like, is this a real thing? Well, some researchers actually looked and said, well, what do pharmacists think about this? Do they think this is a good thing? It's not showing up here, but you look at strongly disagree to not applicable. If you look at comfortable counseling the patient, huge majority strongly agree or agree they can counsel patients. Comfortable performing patient care testing. Some segment weren't doing it. The other segment, very, very large agreement with that. Visit disrupted my workflow. That large sort of turquoise bar there is actually strongly disagree or disagree. So this fits into the workflow. This is how we can do this. And then what do patients think? It's acceptable and feasible. Look at all this. This is still, now it's going the other way. Very satisfied is on the left. All those bars, very satisfied with the way blood tests were collected. Pharmacists worked with the prescribing physician here, privacy of conversation, etc. And so here's our law, right? This is what was passed into law. We're pending regulations now. This is insurance coverage, and Dr. Chan and the Public Health Institute, Rhode Island Public Health Institute, were instrumental in getting this passed and appreciate their support. So this is the Senate version where there's insurance coverage for all formulations of PEP and PrEP. One of the segments in it said not required to cover an out-of-network pharmacy provider. More on that. Expedited prior authorizations. When you think about PEP being 72 hours, the Board of Pharmacy, again, I mentioned those regulations, which they can prescribe, dispense, and administer HIV prevention drugs by those three mechanisms to delegate authority there. Order lab tests. We don't use point of care, that's POC, oral tests, and a training program, which we're already incorporating into our fall semester for all of our students, and we'll have training programs through Rhode Island Pharmacists Association, and the Good Government Pharmacist of the Year, Chris Federico, will be implementing that. The other interesting thing about this bill is it actually defined a healthcare provider for the first time in Rhode Island law, but only regarding HIV preventative medications, that a licensed physician, PA, a certified nurse practitioner or midwife included pharmacist as a provider. So that was great. Some other limitations. This was at least 30 and a max 60-day PrEP supply every 2 years. Had to test negative. Pharmacists can order and verify the test. If it's positive, they refer to PCP. So again, that collaboration. And lacks some symptoms, no contraindicated medications. We have that. CDC authorized counseling or indicated counseling, best practice counseling. Again, more other treatment, whether HIV positive or not, refer people to services, and then it's documented. For PEP, it's just documenting exposure within 72 hours. Do they meet clinical criteria? We offer PEP as well as HIV testing, counseling again, and again, notification of PCP. So we're waiting for those regs. But there's more. So there was a fix to the bill that I'm happy to have provided testimony for, or my student and Dr. Federico did, where we eliminated this out-of-network pharmacy provider. So it's interesting, since pharmacists currently aren't considered providers, they're not in any network. So therefore, no pharmacist can actually get credentialed and paid by an insurer with this clause. So the Senate bill is actually already passed the full Senate and is waiting House approval. The House Bill 7625 has been heard in committee, and we anticipate passage. We are excited for that. And so not only does it eliminate that out-of-network pharmacy provider clause, we eliminate prior authorizations, even expedited prior authorizations, because PEP you need to get within 72 hours. You cannot wait for this. So we're eliminating prior auths is, I think, something that's most providers jump for joy to hear about. The other thing is that we added this, or they added this segment on any not subject to any prevention drug to prior authorization or step therapy requirement. No copay, no deductible shall need to be met. That is true HIV access. So in contraception access inequities, or switching quickly to this. So again, we see the same theme here, where who is not getting these essential public health services and medications. So contraceptions and medications to preserve reproductive autonomy are exceptionally important and have been a cause for many, many Rhode Islanders and advocacy groups over the years. Been trying to pass this bill since 2019. We did it in 2023. So nearly 50% of pregnancies are unintended or mistimed, and it's highest among Black and Hispanic people. Contraceptive use among Black people is lower than in white people, particularly long-acting reversal formulations, and that's something to think about. There are LARCs, long-acting reversible contraception. Thank you, LARCs. And why is this? Implicit bias, lack of health insurance, racially driven medical injustices and medical trauma. And again, I mentioned earlier, contraceptive deserts. So you may say, well, are there contraception deserts in Rhode Island? Well, we'll get to that. We look at racial differences. This is from PRAM's data from a report in Rhode Island. Pregnancy-related mortality rate, again, we see the highest amount is among Black people. And we look at birth complications by race or ethnicity. This is all the full United States. These are both United States, sorry. So not Rhode Island. We see the highest among the Black racial group. So are there contraceptive deserts? Well, this is helpful in this website, powertodecide.org. 64,000 women in need live in contraceptive deserts. And so we look at that on that scale at the top, no health centers with all methods of contraception offered, and some health centers, we see it getting darker purple. There's still room to grow here. 2,310 live in counties without a single health center that provides the full range of methods. So our previous pharmacy resident, Audrey Whalen, Dr. Whalen, and Dr. LeMay, my colleague, and I did a survey of students and customers and pharmacists and clinicians. So this is the data from published from pharmacists and clinicians. So you may say, wow, pharmacists and clinicians probably have privilege and probably have lots of access to healthcare. I can't imagine that they'd have any barrier to contraceptive access. Well, they do. They reported it here. So over half provided no barriers as expected, but all of those barriers listed here that are outlined in red are barriers that pharmacy access to contraceptives can alleviate. Time or delay in appointment. So again, these are the providers. These are the professionals here. No refills, no clinician, no OB-GYN, cost, fear to discuss with clinicians, clinician refusal, transportation. Now, these are small numbers. I want to be clear about that, but I think it's important to point out that they have barriers. So what are the patients experiencing? So from our study here, we look at the perspectives on contraception writ large. So among 98 pharmacists who completed the survey and 64 clinicians, the most common barrier were no refills by pharmacists. And clinicians, it was insurance for their patients. Time and delay appointment, we agreed there, no clinician or cost or copay. Not everybody agreed with this, but a supermajority in both groups. 82% strongly agreed this should happen, 73% of the clinicians. We didn't ask the barrier question for patients from the clinicians, but for pharmacists, again, a very similar list of these barriers, which we could talk about for probably all public health meds of importance, right? No refills, insurance, no clinician. The biggest benefit was the same, increase in overall access. That's what we want. Pharmacists said, and clinicians said, fewer unintended pregnancies. Clinicians said, important public health service. Pharmacists like their scope of practice expanded. So again, it's that support of these services despite healthcare's increasing and concerning increase in people leaving the profession and burnout and things like that. And their most common concern, pharmacists want to get paid. Lack of patient medical records. They want access to those records. We need to work on that. And patient safety. Patient safety was #1 for clinicians. I think that's great. They were concerned about regular preventative exams. I am too. That came up at the hearing where this bill was being debated. And no concerns was the third most likely thing. So here's our law. And basically what it says, the pharmacist may prescribe and dispense all short-term FDA-approved hormonal contraceptions. We have to have this, the boards all agree with this, considering ACOG guidelines. The requirement is there's education, including counseling on all methods. So this is unique to some other state laws. There's about 27 or 28 states that allow this. So they have to counsel on LARCs to refer people to that. Self-screening risk tool. New York just this week came out with their pharmacist prescribing self-screening questionnaire and contraindication list. Is phenomenal. We have to give patient a written record, notify PCP, provide them a list of PCPs. So again, this is about rising tide, lifting all boats. And then of course to dispense as soon as possible. That's the advantage of having public health at the pharmacy counter. Now, the initial prescription is limited to a maximum 3-month supply. That's different than other clinicians. They can write up to a year. All insurers must cover contraceptives that are prescribed and dispensed, including counseling. So it's often confusing. You say, wait a second, don't I have my hormonal contraception or my patient's hormonal contraceptive covered by insurance? But the pharmacist's time to counsel on that is not. The cognitive services are not. Now they are. Pharmacy board is going to track accessibility. That's important. There's a paper that I'm reviewing right now that talks about sort of the challenges and benefits of pharmacists prescribed contraception. And really, it's all about promotion. And so we wrote into our law that pharmacies are going to promote this and Rhode is going to promote this. Okay, so which of the following best describes expanded scope of practice laws this spring? Smoking cessation medication prescribing, including OTC formulations. That's a real bill. It's we hope that's going to pass this year. It's not passed yet. Prescribe and bill Medicaid for HIV prevention medications and lab tests. Prescribe and bill insurers for all formulations except LARCs. Prescribe hormonal contraceptives to adults and bill the patient for cognitive services. So I'll take the first folks here who can do this. What do we have? We've got a B. We've got an A. So the answer is, drum roll please, is C. So as I said, they can prescribe, they have scope of practice expansion, pharmacists do now. They can bill insurers for it. A is incorrect because that's not happening yet. D is incorrect because what I missed, I didn't mean this to be a stumper here, but pharmacists can prescribe hormonal contraceptive to anyone of any age. They can also prescribe and dispense and administer HIV, PEP, and PrEP to anyone of any age. So we can think about that highest group of folks who don't have access to PrEP. Maybe we can do that. And so we can bill. D is also incorrect because we can bill for cognitive services, which makes C correct. B is incorrect because we had that out-of-network clause that we are trying to fix, hopefully by June. Okay, so I've said a lot about referral services and independent prescribing and how we can all work better to expand public health. And so let's talk about ways we can do this. So a lot of this is repetitive, but I have some other data here. So from the Healthy People 2030 website from the Department of Health and Human Services, we want to increase linkage to HIV medical care. So we need to refer people to that care. And I said that's in our bill that was passed in our law. We want to increase, the United States wants to increase the proportion of women who get needed publicly funded birth control services. So Medicaid can reimburse credentialed pharmacists for their cognitive services providing reproductive health care. That's phenomenal. So we have an increased desire. We're doing that in Rhode Island. That's great. This is also from that report here, the insurance status before pregnancy, right? So we see that there are racial inequities here. We need to decrease those to keep following those disparities and see if pharmacy access decreases those. That's an interest of mine. We want more people with the primary care provider. This was a surprise to me. I didn't think this was even a marker, but this is great. As people access pharmacies for these services, and they're not taking on financial barriers or experiencing financial barriers to that, as they are with some other substances or other medications, we hope that there'll be more people with a primary care provider. Increase is desired there. So what are these mechanisms? We talked about contraception, talked about PEP and PrEP. Actually, in immunizations, they need to notify primary care providers there. Pharmacies, as I alluded to earlier, provide harm reduction. We hope that they'll start selling drug testing strips like fentanyl test strips. They already have naloxone, and they sell lots and lots of over-the-counter syringes. The test to treat COVID-19 that I mentioned before. We want to expand this. Hopefully, the feds, in this hugely bipartisan effort to have tests to treat for these communicable, preventable diseases or treatable diseases like flu, strep throat, and RSV. Imagine, there's documents where people have strep throat, they get diagnosed in the pharmacy, they get a shot of penicillin, like a literal IM shot, and they're done. That's it. Nothing to be dispensed, nothing to be lost. Equal efficacy there. So that's an exciting thing. We look at behavioral health, as I've been saying. Contact your senator and representative and say you'd really like pharmacists to prescribe smoking cessation. It's supported by the Rhode Island Medical Society and the American Lung Association. It's a big push for them. And of course, medications for substance use disorders, whether alcohol use disorder or opioid use disorder. I had a grant and we have a vending machine at the University of Rhode Island that dispenses harm reduction products like naloxone and fentanyl test strips and needle disposal. It also has emergency contraception and safer sex kits and pregnancy tests and ibuprofen and all kinds of things there. So that's a way to refer people. We'll soon have, I hope, an iPad to direct people to other care, to direct people to primary care or at least health services when they're accessing that 24/7 vending machine. Lots of states have passed minor ailments and travel medications is another thing that people find difficulty accessing, that pharmacists have the knowledge to administer those travel medications, dispense them through these collaborative efforts. So which of the following requires referral to a primary care provider? Immunization administration, contraception prescribing, prescribing HIV, PEP, and PrEP, or naloxone standing order. There could be more than one answer. I just didn't put a slide for the answers on here. Well, that's all of them. So except naloxone. So yeah, contraception requires referral. Prescribing HIV, PEP, PrEP requires referral. Immunization administration actually does too. So as we screen people for immunization, those immunizations actually go into the registry. So there's sort of now a passive or active way for other clinicians to see what their patients are getting at pharmacies, because we have this wonderful lifetime registry now. We helped pass that 5 years ago now. And naloxone standing order does not. So I think I missed a not in that, but so not naloxone standing order. So that's great. I got through these slides. Thanks for hanging on to the whirlwind. I'm happy to take any questions by chat or from Dr. Chan or verbally.
Wonderful. Thank you so much, Dr. Bratberg, for the presentation. It was wonderful. I obviously learned a lot. I got the last question wrong. I knew it was for B and C. Didn't realize it was for A, though. So thank you. Thank you so much. So if people have questions, please do raise your hand or put it in chat. I have one question for you, Dr. Bratberg, and this, I think as you may know, my wife is actually a pharmacist, so perhaps I'm biased. But just thinking about workforce development, actually, and this is something we struggle in terms of physicians and other healthcare professionals. But, when I walk into pharmacies, I mean, everyone seems incredibly busy all the time. And I think we've seen that as we ask pharmacists to do more and more, can you talk about sort of the burden of this work and how you think about sort of workforce capacity, and frankly, whether or not we have pharmacists to do everything that we want to do?
Yeah, no, that's the essential question, and I'm happy you asked that because I am the first person to not want to ask people to do more when they don't. I don't want to say, "Hey, you're burned out. You know what you need to do? This burnout module, right?" It's pizza isn't helping, as is a meme in pharmacy and I think in other professions. So that's why these payment mechanisms and these privileging mechanisms are so essential. Is that I did a focus group study with a student 3 years ago now saying, okay, if you could pass birth control access or medication administration or smoking cessation, what would you pass or what would you like? And they're like, med administration. We know how to do it. We know it takes the same amount of time as a prescription, but we really are reluctant billing that patient for that service, even though, for example, there are some medications that are administered like vitamin B12 that pharmacists reported to me. The patient picks it up, they go to their physician office, they get charged $120 when pharmacists, and I told that to pharmacists to say, if you charge $20 for this service, the patient is winning here, right? But we really need to have insurance coverage of all those things. So as we expand those cognitive services, we need payment for them at an equitable rate so that we can expand technician kinds of logistical decisions, and other states have done that. So it's really sort of task shifting to say, okay, are we going to pay for another pharmacist by doing hormonal contraception? Probably not, right? Depending on what that's reimbursed. And we know Rhode Island has one of the lowest Medicaid reimbursement rates. But for pharmacists, it goes from zero. It's going up from zero. I think the important thing is that this is public health is the current and the future. We saw that in COVID, which did hurt people, right? And those tests were paid for by the federal government. The vaccines were reimbursed from the federal government. So if we reimburse, the service can be there. We can connect people to other services, and we need to track it. We really need to see, in the contraception bill, they're going to track what usage is. And if nobody takes up the service, we can identify, okay, is this a workforce problem? Is it a technician problem? Do we need to task shift more things to technicians? Do we need to train technicians as community health workers so that patients have greater access to solutions for social determinants of health? That's an effort that Missouri has pioneered, and my colleague MJ has explored in Rhode Island, and I hope that we get funding for that at some point.
I think one key word that you mentioned numerous times is collaborative, but just collaboration in general. And I think sometimes there's pushes by physicians to not let go some of these things. But to me, and I think this is exemplified in the PrEP and the PEP legislation that you talked about, is improving access, finding that balance where patients can have access to some of these medications. And the other key, I think, and probably something we have to work on, is just that referral mechanism as well to primary care. So this is a collaboration between pharmacists, physicians, frankly, all of us in healthcare, trying to find that balance between access, as well as, of course, having the appropriate training, education, patient safety.
Yeah, and I think the key there that everyone struggles with is documentation, right? Why are we faxing things? Like I just don't understand, right? But again, large chains have used, EHRs like Epic, right? And so people are familiar with that. But the problem is that the patient is at a clinic that uses a, eClinicalWorks or some other system. I don't have any investment in those systems. Unlike the VA, which has a system that integrates everybody. Or I was a pharmacist at our URI Health Services. A patient came in with an antibiotic or a birth control prescription. I could pull up their whole history. I could read the note, right? When I rounded at the hospital, I could look at all the same notes that everybody's looking at. And so there's advantages in those integrated systems. And I think the last mile here is really, I think they're interested in it, is connecting community pharmacies to these systems so that we can, again, even if we have to print things and send them, that can be done. And I mean physically print, but sort of take screenshots of things. It's not searchable. It's not ideal from a data analysis standpoint, But having the ability, pharmacists repeatedly say in studies and in anecdotes and in Rhode Island that they want to know more about what the patient's on, like the Paxlovid or other COVID-19 antivirals. I'm uncomfortable because I don't know this person's renal function, or I don't know their pregnancy status. We need ways to have smoother integration there so that community problems are solved in the community with follow-up by prescribing clinicians and pharmacists. And we need people discharged from hospitals getting connected to community pharmacies. It's a hub and spoke kind of thing that I think has workplaces, and we've got lots of great examples to follow.
And Dr. Bratberg, one final question here, and then we'll let you go if there's no other questions. But as we look at the PrEP legislation, and as you mentioned, regulations are in progress here, and even thinking about other medication interventions, et cetera, how does this work when it's actually implemented? Are we going to see like all pharmacists all of a sudden being able to prescribe PrEP or PEP? Is it going to be a few sort of key pharmacists and pharmacies in areas which have sort of taken this on as sort of a little bit more of a specialty? How should we think about this over the next year or two?
So I mean, it'll be advocacy, right? It'll be advocacy and training, and making this, the key thing is to make it normal, and really listening to pharmacists to say, before we even start, to say, find the champions, find the person who says, I did this is great. Don't listen to me. I don't work in a community pharmacy. I'm just a policy person. I'm a professor. So I think what they need is, we need to identify the champions. So think of how we implement things in clinician practices, right? Hey, the clinician said, I know how to do this. What are your fears? I can alleviate them. So champions seem to work. Education seems to work. Making regulations sort of as easy as possible, and really assuring that payment mechanism, right? If this bill passes and we can be in network and prescribe and administer and get paid for those things, that's really going to set it off. We saw this with vaccines. We passed the law in 2007. A few pharmacies offered vaccines, then a few more, then a few more, and then it became standard. And it took some years. And so in the next year, it's going to be like most implementation research, is that one or two champions will come about. Let's make sure they're supported and sustained, and disseminate those best practices to other pharmacists and other pharmacies as they take this on. Importantly, everyone says, well, you need the chains on board. The chains are doing this in other states. So they've got a template on how to do it in Rhode Island. We just need to pass the policy.
Thank you, Dr. Bratberg. And there is one question here about the law and how it mentions that pharmacists shall complete a training program approved by the Board of Pharmacy on the use of protocols, et cetera. The question is that still going to be required? Is there going to be a training program?
Yes, yes, that is. I believe that is in the regulations as well, and that's again from the bill. Again, most of these scope of practice expansions, we look to see what other states have done and how they've championed it, and they have training programs. We have a training program for contraception. In a month, we're going to be teaching our first-year pharmacy students how to prescribe birth control. Those, when they go to their second year of pharmacy school, they're going to learn about PEP and PrEP, and those programs integrated into our curriculum are going to look almost identical to what we educate practicing pharmacists about. And so I'm sure Rhode and other advocates for HIV, PEP, and PrEP would love to make sure that we have sort of as low a cost as possible training program, as accessible as possible to do that. And there's lots and lots of examples in the at least 10 or 11 or 12 states that have done this. California leads the way, I think, in PEP and PrEP. So yes, it is a training program, and we will make sure that you get trained.
Thank you, Dr. Bratberg, for that. And I see Dr. Bornstein is also on. And I just want to reassure people that there's a number of us at the Department of Health and elsewhere that have a lot of experience with HIV PrEP. So as we start this process, we will, both on behalf of the Department of Health and other clinics in the area, we'll be offering some resources and some safety net referrals for things for both PEP and PrEP. So some access to experts, et cetera. So we're excited this is happening. And I don't see any more questions, Dr. Bratberg. So I'm going to thank you again for presenting. Thank you for sharing your time and your expertise. Appreciate it.
Appreciate it so much. And I'm easily found, so I'm happy to find those champions right now and help you out.
Wonderful. Thank you again, Dr. Bratberg, and thank you
Thanks,
everyone
Cal.
else for attending. Have a good day.
Thank you.